Hi, everyone. Welcome back to the channel. Today, I have a really interesting interview with Dr. Vedahi Dadania. She is a board-certified ophthalmologist. She is also an associate professor of ophthalmology at NYU Langone, and she is the director of the Retina Fellowship in the Department of Ophthalmology there. We're going to talk about how she was the primary ophthalmologist on the world's first eye transplant that was done at NYU in May of 2023. So we're going to get into what the success of this surgery was, who all participated in it, and what this really means for the future of eye care. Thanks, Dr. Dadania, for being here.
Thank you, Dr. Nagori, for having me.
All right, so let's get into it. So tell me about lay the background for this eye transplant. What was the patient's background and what was the need for the transplant?
So this is all publicly available information. Aaron James, who is our patient from Arkansas, sustained a high voltage electrical injury to his body. And in that injury, he had severe damage to his face, where he really couldn't eat. He didn't have a nose, and he also lost his left eye, as well as a portion of his left arm. So that injury had occurred, and given the impact it had on his life regarding what his ability was to function, or just even going outside in public, going to a restaurant, we evaluated him at NYU Langone as a candidate for a potential partial face transplant. And then because he had lost his left eye, as a whole eye transplant included with that partial face transplant. And our reasoning behind, well, let's go ahead with the eye transplant, and it's multifold. But one reason is that the eyelids and the face transplant heals much better with something within it. If we just transplanted his eyelids and a portion of his face without anything there, the way that the eyelids would scar and the appearance, the cosmetic appearance from it would not be as aesthetically pleasing as if there was something there. And so that was kind of what prompted us to decide to include the eye transplant for him.
So this is obviously a patient who requires multiple doctors to be involved with all the things that are going on. How was your team structured and who else was involved in the surgery?
So we actually had a really large team. The entire team itself was about 140 people. This included specialists from our plastic surgery team. This included specialists from our transplant team. This included specialists from radiology, as well as a number of specialists across NYU Langone. And what we did was we had to work together to figure out first how best to perform this partial face and whole eye transplant. And for example, what that includes is how are we going to provide a blood supply to the eye before we transplant it over so that we can try to preserve as much of the eyeball as possible. We also had to work with our transplant team and immunologists to devise the best regimen, to come up with the best medication regimen to prevent rejection of the graft from the patient who's receiving it. There's a lot of imaging involved in understanding this. There's a lot of imaging involved in after the transplant is done, looking at how is the eye functioning, how is the face, and so we had to include a lot of different specialists to help us with that.
And in the surgery itself, who was doing the primary reconstruction?
So the actual reconstruction, the technical components of the surgery was done by our plastics team, led by Dr. Eduardo Rodriguez.
So as the primary ophthalmologist on the case, what did you evaluate sort of beforehand, pre-surgically before going into the case?
So we evaluated a few things about the eye in the donor. We wanted to make sure the eye had a good blood supply. And so we did something called fluorescein angiography. Just like you can do an angiogram of the heart or of the brain to understand the blood vessels, we can do that of the eye to make sure that there's a good blood supply. Really, we wanted to transplant a healthy eye. We also did a very thorough examination of the eyeball to make sure that all components of the eye were healthy. For example, is the cornea, which is the front of the eye, clear? Is there anything else going on with the eye that would impact the success of the transplant?
And how long was the overall surgery? Because you had mentioned that there were multiple things that were going on. So I know just the eye was not transplanted. There was a whole, plastic surgery happening. So how long was the total surgery?
So the total surgery was 21 hours, and how it occurred was in two operating rooms at the same time. In one operating room, the donor was being prepared in terms of taking down the graft, the partial face, and the eyeball, isolating everything that we needed to transplant over. And in the other operating room, our recipient, Aaron, was what his face was being prepared to then receive the graft from the donor. And this it's quite meticulous in regards to, well, the blood supply, for example, needs to be connected so that you minimize the amount of time that the eye or that the face has no blood supply. And so this takes time to do. In this situation, one of the things that helped make this successful was that for the eye, the blood supply was actually, there was what we call an anastomosis, or a second connection made before it was removed from the donor, to allow that eyeball to continue to have a good blood supply and to minimize the amount of time that it would not receive blood when we moved it over to the recipient.
So that was an anastomosis that you guys created, or was that just happened to be luckily present?
No, it was an anastomosis that was surgically created.
And then when during the surgery was the eye portion of it actually done?
It was actually all transplanted together. So the eye was transplanted with the face, the eyelids. It was all one large graft or transplant. It wasn't separated from the remainder of the face.
So as we know, the optic nerve is one of the most critical nerves for vision. So how was the optic nerve connected from the donor graft to the recipient?
Great question. The optic nerve from the donor was cut at the longest possible point, so that when it was transplanted, we would have there would be some slack in the optic nerve because we expected swelling. In the donor, we were able to find the stump of the previous optic nerve when the eyeball had been removed from the patient after his initial injury. And we reconnected the two by sewing them together with stitches. And within that nerve sheath, specific stem cells were injected. And that was based on some early research that has shown a potential for improved optic nerve regeneration with the stem cells.
That's really fascinating. So there was some hope that maybe some kind of function might be recovered with the stem cells.
To be frank, when we went into this surgery, we went in with the understanding that it would be highly unlikely this patient would ever even see light. But we did include that component, as there is a lot of research being done on optic nerve regeneration. And it was something that we could incorporate into our surgery to potentially provide this patient the best chance of success.
So when we're talking about success, let's talk about the fact that this was, I mean, the first eye transplant done ever on planet Earth, which is totally insane. And I'm so grateful to even know you and be able to talk to you about this. Yeah, talk to me about the success of this surgery and what that means.
So as you touched upon, this is the first successful eye transplant. And what I mean by that is we've never been able to take an entire eyeball out of one patient and transplant it to another human and have seen that eyeball continue to have an excellent blood supply and to stay nice and round. And what I mean by that is when an eye stops functioning well, it actually shrivels up. If you think about a grape left out in the sun too long, it shrivels up into a raisin. So the fact that this eye has not shriveled up yet, the fact that it continues to remain nice and round, tells us that the eye is receiving enough of a blood supply and nutrients to allow itself to make the fluid within the eye to keep it nice and formed. And we liken that to how our body and our bone marrow is able to make blood cells on a continuous basis to allow us to live. And so that's the first step. The next step is we can also see that there's an excellent blood supply to the retina. So when we do that testing I talked about before, the fluorescein angiogram, early on, when there was a lot of swelling in the graft, the time for the blood to go from the arm where we do the injection to the eye was a little bit longer. Within a few weeks, it actually normalized to what we would expect in any of us when we would inject that dye into our arm and see it go to the eye. And we see that the retina really does have a full supply of blood, providing it with nutrients. Now, the other aspect of when we think about success is, can this patient see? And at this point, this patient cannot see. He cannot perceive light. And what I mean by that is, if we shine a light into his eye, he cannot tell you that he sees that light. And this is because the optic nerve had to be severed or cut and then transplanted. And we know when the optic nerve is damaged in that form, light cannot be transmitted through the eye, at least from what we've known in the past.
Hi, everyone. If you've enjoyed this interview thus far, be sure to hit the like and subscribe button below. It not only helps the channel, but helps out all the people that we interview. Thanks for watching. What do you see as the future of this kind of surgery? Like, because you had mentioned, and I've seen this in patients as well, where the eye does become, we call it tisicle, or shrivels up when it's no longer functioning. And that is something that is cosmetically not great for patients. And do you see this as something that could be offered? I mean, granted, a 21-hour surgery is not realistic for a lot of people. But what are your kind of thoughts on how this can be applied to other patients?
Yeah, so at this point in time, the eye transplant was successful because it was transplanted with the partial face. Because as we put the blood supply together and moved it from one patient to the next, we minimized the amount of time that that eye was without a blood supply. And that was only really possible because it was done with a partial face. Over time, we would hope that we can continue to evolve and advance this field so that we can potentially bring sight to patients who have not had sight before. This is just the first step in understanding how that's possible. And to just put in one more plug here that's really important is this patient is on a very unique and strong immunosuppressive regimen so that he does not reject this graft. And that's also something that we think about as being part of his success. So one thing I forgot to mention before is when we look in his eyeball, we don't see any signs that his body is rejecting that eyeball or that graft. And that is important to think about when we think about the future of whole eye transplants as well.
Right. So it does seem like this patient had a lot of other things going on, including loss of his facial structure, facial bones, which justified all of this medical intervention. And when we see patients now in this day and age that have lost an eye that has now become shriveled up, they usually will get a prosthesis, which is a more limited procedure, and then have a shell placed over the eye. So it does look like a real eye and maintains the structure of their face. But that's why you kind of need that prosthesis. And what's interesting in this case is that because the blood is being provided to the eyeball and it is still living tissue, may not be functioning tissue, but I guess it's living tissue. I don't know if you would agree with that statement. But it's maintaining its shape, and at least blood is running through it.
Yeah. So in regards to that is exactly correct. And with this partial face and whole eye transplant, Aaron is now able to eat food, and he's functioning is a lot different. His nose is there where he can now smell, and he wasn't able to after the accident. When we think about the risk benefit for Aaron, the benefit of undergoing this partial face and whole eye transplant really outweighed some of those risks for him. The other point you bring up is functioning. So yes, Aaron cannot see from that eye. When we stimulate the retinal cells with light to see if they have a reaction, they do. They actually give us a response back on our testing. That is another measure of functioning. That said, he cannot see and say that he's able to see anything. And so we really bring it down to that in terms of where we stand right now. But what's really, really remarkable is how well that eye continues to look over a year out, and the possibility of potentially advancing upon this so that he could potentially have sight.
So of course, after such a massive injury, there is a part of this that's just cosmetic to make sure that the patient can, go out in public and feel comfortable. What else is really interesting and intriguing about this as we look forward to functionality with a whole eye transplant?
Yeah, so there have been devices in the past that require an intact eye to help transmit signals and allow a patient to have better vision. And so if we can find a way to combine various advancements or build on top of them to have a patient perceive even light when they previously couldn't see anything, that can really impact someone's life. And so this is just the first step in transplanting an eye from one patient to the other. Having it continue to remain in the body of the donor and continue to function in the body of the donor. The next steps will evolve into hopefully bringing some level of sight to patients. And that can happen in a number of ways.
Yeah, you really need, as you had mentioned, like sort of the scaffolding kind of present to even advance functionality. You need you need the eye there to work further on it. So it's really, really interesting. I'm so grateful for your time. Any sort of final words to our audience on, maybe if they have lost vision, and we know corneal transplants are done fairly regularly, but this is really phenomenal, and this is kind of what we talk about on this channel is just these things that are happening in healthcare that are absolutely amazing, and kudos to you and the whole team at NYU, and the plastic surgeons that were involved, as well as the 140 people you mentioned that they're doing this surgery. Any kind of final words from you on that?
So first I'd like to thank the team at NYU, which is really extensive. It took a lot of people to make this happen, led by Dr. Eduardo Rodriguez, and our supportive chair in our Department of Ophthalmology, Dr. Catherine Colby. And I would really like to say thank you, Dr. Nagoria, for having me today. And to the patients out there, we have so many people across the world really working to try to save, preserve, and even bring back vision for our patients. And being a part of this and working to help improve the quality of lives of our patients is why we do this every day.
Awesome. Thanks for being here.